The Agenda with Steve Paikin is made possible through generous philanthropic contributions from viewers like you. Thank you for supporting TVO's journalism.
A new variant has everyone concerned. So tonight we'll do something like a state of the pandemic. First, what is and isn't happening with Omicron, breakthrough cases, and vaccine efficacy. Then, new antiviral drugs and other treatments show great promise. We'll find out how soon they might help here. And, love 'em or hate 'em, we'll assess how wearing masks has evolved throughout COVID-19 and beyond. It's Thursday, December 2nd, and that's ahead on the agenda. Many people had hoped that vaccines would mean the end of COVID-19 post-haste. Then, as breakthrough cases cropped up, so did concerns about vaccine efficacy and virus transmissibility. Now, with a new Omicron variant entering the fray, let's clear up any confusion about what's going on. Joining us now, immunologist and researcher Jennifer Gomerman, who joins us from the Discovery District on the downtown campus of the University of Toronto, where she is a professor of immunology. And Dr. Gomerman, it's good to have you on our program. How are you doing tonight?
Great to be here. I'm doing well. Thank you.
I guess I want to start here. Why are the breakthrough cases as high as they apparently are?
Well, as we vaccinate more and more people, of course, there are fewer and fewer people who haven't had the vaccine, and therefore breakthrough cases are going to be focused more and more on the vaccinated. So that's partly a numbers game, but it's also important to keep in mind that these vaccines were designed to protect us against moderate to severe COVID-19 that requires hospitalization. And so the vaccines actually weren't designed to prevent what we call transmission, person-to-person transmission. And so breakthrough cases are actually expected to happen. They're actually not happening as much as we thought they would, because there is apparently some immunity within the upper respiratory tract that is preventing transmissions. You're not a sitting duck, but they will happen, and that is expected.
All right, let me follow up with this, because, of course, for the first year or more of COVID-19, everybody who got it, I guess, run-of-the-mill COVID-19. And then the Delta variant came, and then we realized that almost everybody in the hospital had Delta. And now Omicron's on the way, we're told. Do we yet, when I say we, I mean you, have a good sense of what kind of COVID-19 most people are getting these days?
Well, let's talk about Delta first. And so the key thing about Delta is that it's highly transmissible. And so when you get it, it's also very good at infecting us, and so you get a larger viral load. That can cause more severe disease. We know that high levels of virus are not good. But really the main difference with Delta is its transmissibility. It can really just rip through a school or a congregate setting in a way that the previous variants were slower to do. Now, Omicron, which we're hearing about quite a bit, and I'm involved in COVARNet, which is a government-funded organization that studies variants as they emerge. Omicron is worrying because it's possible that it will also have the same kind of transmissibility as Delta, or maybe even more. We really don't know what's going on yet with Omicron until the experiments that are happening in labs right now reveal whether it's going to be more transmissible and what impact it's going to have on the pre-immune population, so people who've had COVID-19 or people who have been vaccinated.
In which case, how much do you think we ought to worry right now about waning immunity?
Well, I've spoken about this before to the media. I don't like the word waning because it really implies something very negative. We know that our antibodies that were provoked by vaccination or infection will not stay super high forever. That's not physiological. We know that as time goes, your antibody levels will decline. That's important because we need to make room for other immune responses to happen. So we have declining antibodies, and antibodies are, I guess you could think of them as the first firewall that the virus has to contend with if it wants to get inside our body. And so as our antibody levels decline, breakthrough infections will become more common. But it doesn't mean that moderate to severe COVID-19 is going to start appearing everywhere. It might happen in people who are immunocompromised, but if you have good immunity, there are other ways the immune system kicks in to deal with a breakthrough infection. And that's called cellular immunity. So the immune system is kind of like a Swiss Army knife where antibodies are just one tool. But if the virus gets past those antibodies, then the cellular immunity that's inside our body can deal with the virus.
All right. At the risk of being a little too self-indulgent here, let me use myself as an example, and then I'll get your conclusion as to where we are. I've had 2 AZs, AstraZeneca shots. I've had 1 booster shot, which was Pfizer. Mm-hmm. I've also had COVID-19, so I have those natural immunities built up as well. Am I in reasonably comfortable positioning for not getting Omicron?
Provided you are a healthy person, then you are in reasonable shape for not getting moderate to severe COVID-19 caused by the variants that we have looked at so far. With Omicron, we simply don't know yet how good our immunity is going to handle that virus. We know that when you're immunized, you generate cells that actually get better and better over time. So these are called B cells, and they become memory B cells. And if they're reactivated, they become antibody-producing cells. And those memory B cells, over quite a long period, we know at least 12 weeks, can keep going through an immune response and keep learning more and more about what you were vaccinated against, and that is the spike protein. And during that process, we do know, and this is published data, peer-reviewed data, that the breadth of the immune response actually increases over time. So your immune system is better able to deal with variants. Now, whether it's going to be able to deal with a variant like Omicron is obviously the $60 million question that labs all over the world, including labs in Canada as part of COVARNet, are looking at very intensively. But from what we know about the immune response, there should be some immunity even to variants like Omicron. But the data have yet to emerge to really validate that statement.
Well, this is the big concern, right? Because I guess we're up to about 80% of Ontarians right now or almost 80% who've been double vaxxed, and now some people are going off and getting their booster shots as well. And I'm sure they are asking the question, am I doing all this for naught, given that Omicron may be more powerful than any of the inoculations that I'm taking? What would you say to them?
Yeah, well, that's a super fair question that's on everyone's minds. But when you have been vaccinated, you are not starting at square one. You've generated immune response that is going to have some cross-protective immunity. So for example, so far, the variants we've seen, the one that's the most divergent is beta. So this is the variant that was first detected in South America. Beta had a lot of mutations where the antibody response to beta took a hit. It wasn't a complete nullification of that antibody response, but definitely took a hit in terms of its ability to neutralize a virus in a dish. Now, the cellular immunity, in particular the T cell response, did not take a hit against beta. In fact, some of our T cells can recognize SARS-CoV-2 that have been previously trained to recognize other circulating coronaviruses. So this exquisite specificity of the immune response is a little more relaxed when it comes to the T cell response. And so if we take beta as an example, and it's a good example because it's the most mutated of the bunch, then hopefully T cells will still be able to respond to Omicron. And I think there's a good chance they will. So no, what you are doing is not for naught, if I can use a double naught. So people should, if they haven't been vaccinated, this is the best way that they can prepare for Omicron. And we know that vaccine companies are already adjusting their vaccine strategies to deal with Omicron. But they did that when beta came out as well. Vaccine companies quickly modified mRNA templates to deal with beta. And what they found was that when mice were immunized with the beta-specific vaccine as opposed to the original recipe mRNA vaccine, neither animal showed any differences in their ability to clear a beta SARS-CoV-2 variant. So that's teaching us that the immune response is pretty good at dodgeball. And, it's pretty good at dealing with these variants. Whether this will be true of Omicron, again, remains to be tested in the lab.
Well, that's the tough part about all this, right? Every time we think we're catching up, this thing mutates and says, well, you think you've caught up? No, we've got another trick up our sleeve. Is this the way it's going to be for the next, who knows what, years, decades?
Well, it's anybody's guess. We haven't had a virus quite like this before. It's possible that, like influenza, where we need yearly boosters because the virus itself changes from year to year, that maybe we'll need to do that as well for SARS-CoV-2. And ordinarily, we would vaccinate in the fall, but this pandemic and the timing of vaccine rollout didn't let us do that. So boosting now is sensible for some of the population, for example, people over 65 and people immunocompromised. But ordinarily, we'd be doing this in the fall. And that would prepare us for the winter and prepare us against whatever variants have cropped up. So maybe that's what will be the path going forward. I think it's also important to remember that if you're vaccinated, it doesn't make you bulletproof. You can still get a breakthrough infection. You still might get mild COVID. I think we have to accept that this is not a panacea and that it's going to be our best tool for fighting SARS-CoV-2. But in times of high rates, we're going to have to also exercise other public health measures. So that's the best I can do for predicting the future. I wish I had a crystal ball.
No, that's pretty good. That's pretty good. And I hear you on the issue of breakthrough because I was double vaxxed and got it anyway. Now, presumably, I got a less severe case of it than otherwise would have happened because I was double vaxxed, but it was still plenty nasty, I can assure you. Let me do the comparison, though, with vaccinated people and unvaccinated people. Do they both have the same likelihood of transmitting the virus?
No, they don't. And that's another reason for us to not throw up our arms and say, I'm not going to get vaccinated, this isn't going to work. It is going to work. It is going to blunt transmission. And the reason for that, we know that if you get a breakthrough infection with Delta, and if you are vaccinated versus unvaccinated, you'll have pretty similar levels of virus in your nose and in your mouth. But you're going to shed that virus for much less time if you're vaccinated than if you're unvaccinated. So you have much lower chances of spreading it to more people. There's also some data, I don't believe it's yet published or in a peer-reviewed journal, but it's in a preprint format that shows that the virus that is in the mouth or nose of a breakthrough infected person is less able to infect cells in a dish than the person who's unvaccinated. We don't know why. That could be because of those antibodies, that firewall I was telling you about. Maybe they're sticking to the virus and that's keeping it from really infecting those cells in a dish. We don't know the mechanism. But between that and what I told you a second ago about the longevity of how long you're infectious, I think that really does cut down your ability to transmit. And let me give you an example. One of my colleagues, her daughter, under 12, had not yet been vaccinated, and she got COVID at school. And they didn't know until the school reported another case, and then they realized she was positive and she had to stay home. Now, thankfully, she's fine. She did get a bit sick. But what is incredible to me is that her parents, who are both double vaxxed and were definitely sharing the same space, same meals, the same environment with their daughter for several days while she was infectious, did not have a breakthrough. So I think for a lot of people, they're not going to experience a breakthrough, at least at this moment. As their antibodies decline more, then those breakthroughs will become more common. Okay,
that's an encouraging story. Just in terms of that young student, now that she has that natural immunity, having received COVID-19, you still recommend she gets the vaccine anyway?
Absolutely. So the recommendation, so immunity with the vaccine has been proven to be better than immunity with COVID-19. And it makes sense because the vaccine is focusing the immune response to the spike protein, which is really that's the entry mechanism that the virus uses to get inside our host cells. So if we focus our immune response on that and not any other distracting elements of the virus, we're going to have sharper, better immunity. And so, yes, if you've had the virus, you should still get vaccinated. You'll want to consult with your doctor in terms of how long to wait after you've recovered. But really, people who've had the virus and then been vaccinated, they have immune superpowers. It seems that their antibody response and their cellular immunity is really very good. So why not enjoy that? Because that might actually help even more against emerging variants, although we don't know that yet.
Well, that's the thing. I had lots of people joke to me that, oh, you got superpowers now. You're triple vaxxed and you've had the disease. And I say, yeah, and now here comes Omicron. So we don't know whether we don't categorically know whether any of what I've been able to enjoy so far will actually protect me against that. And so my next question for you is, are you satisfied that the country is doing everything it needs to be doing in order to prevent Omicron from going through the population in the way that Delta did and Beta before it?
Absolutely. So I mentioned I'm part of COVID-19. I lead the immunology vaccine pillar of that initiative. It's a CIHR-funded initiative to study variants of concern. We've met several times already since Omicron came out. We are actively trying to get a viral isolate. I know that National Microbiology Labs is really in Winnipeg is totally hot on the case. And so there's a lot of things that happen immediately. And I think, the government has invested money in pandemic preparedness through organizations like COVID-19 and others. They did this in 2003 as well, when SARS emerged in Toronto, but it wasn't maintained. And so I think now we really do have excellent infrastructure in place to rapidly respond to variants of concern. When COVID ends, and it will end, I would urge that we not dismantle that infrastructure, because we will have other pandemics in the future. And it's really not easy to build that infrastructure. It's very interdisciplinary, it's very reagent intensive, it requires a lot of paperwork to make sure we can move samples around, et cetera. So it's really important that once this is over, that these really effective mechanisms for dealing with very rapidly with emerging variants are kept.
Better not to start from scratch next time out.
That's right.
Got it. That's Dr. Jennifer Gommerman, Professor, Immunology, University of Toronto. We're really grateful for your time tonight here on TVO. Thanks so much.
Wonderful to be here, and thanks very much.
The number of people in intensive care due to COVID-19 climbed again this week in Ontario, hitting a level not seen since mid-October. Ontario's Chief Medical Officer of Health said Monday that getting more treatment options is on the province's to-do list. And with us on what those options could entail, we welcome in Hamilton, Ontario, Dr. Zane Chagla. He's infectious disease physician at St. Joseph's Healthcare Hamilton and associate professor of medicine at McMaster University. And we're happy to welcome him back to our airwaves. How are you doing, Dr. Chagla?
Well, how are you?
Just fine, thanks. All the better for having you on, because you're going to answer all our questions about how COVID-19 antivirals work. And before you and I do a Q&A on that, I'm going to ask our director, Sheldon Osmond, to bring up this chart, because we want to go through a couple of the options that are on offer right now. One of them is called Molnupiravir, and the other Paxlovid. And we want to go just through a bit of a comparing and contrasting on these two different drugs just to see where we're at. So let's get the developers up there. For the first one, Merck & Company and Ridgeback Biotherapeutics. For Paxlovid, it's Pfizer. Everyone's heard of Pfizer. In terms of efficacy, for Molnupiravir, 30% reduction in hospitalization and deaths, previously believed to slash the risk by 48%. For Paxlovid, 89% reduction in hospitalization and death. And how about for authorization? The United Kingdom has offered conditional authorization. It has earned FDA recommendation for emergency use authorization, and it's under review by Health Canada. That's the first one, Molnupiravir. And for Paxlovid, there are no approvals yet, and it is under review by Health Canada. All right, that's those two. We want to get Dr. Chagla in here right now, and we're going to do some comparing and contrasting. For example, when you look at these two, what are the similarities between them?
I mean, number one, they're pills, right? And so we have no oral treatments for COVID-19, and the therapies we're currently using are mainly intravenous and have logistical issues based on that. So, having oral options for COVID-19 is going to be incredibly important because it gives us a lot more treatment options. Number two, these two therapies, their success really depends on when you initiate them, right? And we know with antiviral compounds for other illnesses, like the antivirals we use for things like chickenpox or shingles, earlier treatment leads to better outcomes. This is when the virus is replicating aggressively, and when antivirals that shut down viral replication are going to have the most effect. When you let the disease progress to when people end up in hospital and ICU, you start seeing the complications of inflammation and not necessarily the viral complications at that point. And so these therapies, unfortunately, don't work at that point. The molnupiravir compound was trialed in hospital and actually didn't do a lot. Really, the biggest effects were early. So again, oral therapies, early therapies, but certainly that reduction in hospitalization and death that's seen between two of them, which is, again, something that's an advance that we've never had in an oral therapy.
I don't know if you've got hard data on this, but I bet you've got anecdotal evidence on it. Do you know if there's a significant chunk of the population that won't get vaccinated because they're afraid of needles, and therefore being able to take a pill might get them on board?
Yeah, I mean, there's different pieces of people not wanting to be vaccinated. Some of it is needle hesitancy, but many it's more related to the mechanisms or the actual thought of the vaccine and what it does rather than the needle. So we certainly do have patients, for example, that have not wanted to be vaccinated that have accepted intravenous therapy, which is more invasive than a single needle. So needle phobia, certainly may be a niche for this, but it may be just more related to people that choose not to be vaccinated in general for whatever reason.
Okay, let's get back on the path here. You talked about the similarities between the two options. How about the differences between the two?
Yeah, so mechanistically, they're different. They act on different targets. So molnupiravir works on what's called the RNA polymerase, which is how the virus essentially replicates. And so it actually tries to mimic the nucleic acids of the virus. And so, as the drug is taken up by the virus, it tries to incorporate it into new virus genomes. The drug basically makes that defective, and essentially the virus can't replicate anymore. So really good effects in that sense. And again, very similar to some of the drugs we use for things like shingles, which have similar mechanisms of activity. Paxlovid is a compound that's called a protease inhibitor. And so once the virus replicates, it makes a lot of different proteins that are used to, put together new baby viruses. When protein synthesis happens, they're done as big sheets that are eventually chopped apart into little viral segments. And so this molecule essentially blocks that ability for the virus to be cut apart. And so that you get non-functional viruses out there. And again, a similar class of medications that's been used for HIV for some time. And in fact, this Paxlovid compound is actually two drugs. It's the Paxlovid drug, but actually another HIV drug that's been used that has a similar mechanism that boosts the level of this drug in the system in order for people to get as high a dose as possible without having to deal with some of the toxicities.
This is definitely not the most important question I'm going to ask you tonight, but I do want to know, why do the pharmaceutical companies give these drugs such weird, odd, unpronounceable names?
Yeah, I don't know. I mean, the scientific names usually come from, molecular structures or that type of thing. But these, names, they have focus groups and meetings in terms of how to actually brand these drugs. And you can imagine if it's a tongue twister for everyone, how they're going to market them. But for some reason, the name of antimicrobials has just gotten more and more complicated by the day. It's almost a thesis in terms of how to deal with them. But, that's the way it is. And I guess they'll roll off her tongue eventually.
Okay. Back on the path here. When something like this happens, of course, people get very hopeful. So I suppose it's important for us to remind everybody that there will be limitations on these drugs as well. What are those limitations?
Yeah, I mean, number one, there's going to be a global supply of these drugs. And so, knowing, we are a small market in Canada, there may not be as much access as we would like unrestricted. Number two, you have to find prescribers that are willing to prescribe these drugs. And so, people with clinical experience, people need access to primary care providers that can administer them, or other healthcare workers in the community that are able to administer. Number three, they're not 100%, right? And we talk about, for example, molnupiravir, where the people who got placebo had about 9% hospitalization rate versus 6% who got the drug. Well, that means 6% of those people who got the full course of the drug still ended up being hospitalized. And so, they're not a full solution. And unfortunately, especially in people with multiple comorbidities or of a particular age, this may reduce the risk, which is great, but it by no means takes the risk to zero. And often, again, more preventative therapies like vaccines offer way more benefit in this context.
Is it accurate to say that there is actually not that much peer-reviewed data as it relates to these two drugs?
Yeah, so all the information for these have been either released to healthcare agencies like the FDA and the UK Drugs Administration or Health Canada, but there's not been peer-reviewed studies reviewed in a scientific journal. There's not even been a preprint of these studies. All the scientific community outside of the regulators have seen press releases at this point. And for molnupiravir, we saw a press release 5-6 weeks ago around Thanksgiving, showing that, a 50% reduction in hospitalization. We just saw a press release about a week ago showing that actually dropped down to about a 30% reduction in hospitalization. And so, again, this is where it gets a little bit dicey in terms of these drugs getting out there. You want peer-reviewed information. You want us to be able to review these drugs appropriately as providers and scientists and guideline advocates in the community. But a lot of COVID has been medicine by press release, unfortunately, and we're seeing it even more right now.
In which case, if you don't have all of that peer-reviewed data that you would like to normally have, what questions do you still have about these two medications?
Yeah, so number one, exactly what groups saw the most benefit, right? So as we're, again, probably seeing this as a limited resource, are we going to prescribe it to everyone? Are we going to, focus it on certain groups? Are certain groups overrepresented in terms of what benefits they got and other groups underrepresented? You want to see safety profiles. Now, they've said that the safety profiles are reasonable, but again, you want to see if there's been serious adverse reactions, if there's serious drug-drug interactions that we need to monitor for. Because again, clinical trial participants are, well-chosen, cherry-picked, well-developed patients. When you start going into real life, you really do have to start looking at, patients that have multiple complex issues, multiple interactions, multiple drug intolerances, and again, what that means. And then finally, you want to see data around, the robustness of this across all data sets. And I think this is where the molnupiravir compound came up a little bit, even though it was approved. You saw one analysis of the data showing 50% benefit. You saw another analysis of the data showing 30% benefit. So you really need to break that down and say, what was the difference here between those groups? Was there an overrepresentation? This is a multi-center, multi-country study. So was it just certain data from one country that showed a benefit versus another country, which again may be related more to healthcare in those countries as compared to the drug itself? And so again, if you're going to make a guideline recommendation for these drugs, you really have to be certain in terms of their effects being stable, persistent, and that your patients would actually benefit from them as much or in the same ballpark as the clinical trials.
Are you yet satisfied in your own mind that you know how effective these drugs could be against, let's say, the Delta or the new Omicron variant?
I mean, the one positive mechanism of these drugs is they work internally on the virus. So they work on viral mechanisms of replication, of protein synthesis. As we talk about different variants, the major issue that seems to be changing is the spike protein. So these drugs don't target the spike protein, meaning that their ability to be conserved throughout things like Delta and Omicron would be at least reasonable. In fact, molnupiravir has data, and I think Paxlovid has data for Delta, at least as part of their clinical trial. So, there is where the hope lies, is that we will always have consistent therapies that don't rely on us having to necessarily go to the spike protein like our monoclonal antibodies. So, that is the one benefit of this development, and the one benefit of the pharmaceutical industry really looking at antiviral compounds as a long-term solution.
Let me throw another one of those fancy titles out here now. Monoclonal antibodies. Mm-hmm. Okay, let's start there. What are they?
So monoclonal is really just means one type. And so these are one type of antibody. There are two on the Canadian market. One that is made by Roche, a compound called casirivimab imdevimab, and the other by GSK, which is a compound called sotrovimab. And so, when you think about antibodies, these are the proteins that bind to the virus that we make after we get vaccinated, if we get infected, and they're what leads to our immune response. They bind to the virus, they stick to the virus, and that leads to clearance from the immune system. It leads to the virus not getting into our cells and leading to more replication.
How widely are they
monoclonal antibodies?
I'm sorry, go ahead.
Sorry. No, go ahead.
Well, I was just going to say, do you know how widely they're used in Canada at the moment?
Yeah, so monoclonal antibodies essentially are these. We give them as humanized antibodies or synthetic antibodies that mimic human antibodies in that sense. They're approved in Canada, and in fact, the two compounds that I mentioned have been approved for the last few months. The implementation issues of these drugs have made it a lot harder to actually get to the market and get to patients. And this is because it's an IV infusion. It has to be given again within a certain time interval of testing positive and having symptoms. An IV infusion for a COVID patient means that you have to go see a COVID patient. It can't be done remotely. You have to actually put in the IV and observe them. People are obviously worried about side effects with infusions and drugs that are going intravenously. So, they have been available. They've been used around the world. They're actually quite, recommended. They're the only drug that's actually recommended by the World Health Organization for the early treatment of COVID-19. But the implementation in Canada has been a bit piecemeal. The Public Health Agency of Canada has bought these drugs. They are sitting in all the provinces for distribution. But again, local solutions have made it a little bit difficult to kind of make this a reality for all patients who need to access them.
Is their use more widespread in the United States?
Yeah, absolutely. I mean, we saw this throughout the last wave in the United States. Some states like Florida actually doubled down on this as part of their reopening strategy to have easy access. So thousands and thousands of clinics in the states, they're paid for and I think federally subsidized. And so, they're recommended for all sorts of patients aggressively in the United States for the treatment of early COVID-19.
We know that there are more and more people who are getting COVID-19 and for whom the symptoms are not going away, the so-called long COVID. It sticks around and the effects are quite persistent and quite debilitating for some people. Do you know whether these medications would work on long COVID?
Yeah, and this is where the origins of long COVID come from, right? So, there is some discussions around whether or not this is a chronic inflammatory disease and is autoimmune mediated, where, these compounds may not benefit as much. But certainly there is, maybe a still an infectious component. And one of the interesting things that's come up is people who are vaccinated, who have long COVID symptoms, a small minority of them, probably 10-15%, actually get profound changes in their symptoms after vaccine. It really does bring into the question of whether or not all of the infection is gone and mechanisms like this may actually trigger the immune system to clear the rest of it. So, there is a lot of look at monoclonal antibodies as a adjunct to long COVID in terms of describing. It's not there yet, and I think there's a lot of work that needs to be done. But certainly, we know COVID-19 and long COVID often is associated with severe outcomes from COVID-19. And so, these drugs have the ability to at least lower the severity of disease. So, they may be able to prevent long COVID complications for, again, people who are able to access them in the manner that they're prescribed for.
Is there an argument to be had here which suggests that if you took these medications prophylactically, as in, preventatively, that they might be useful under those conditions?
Yeah, absolutely. So the monoclonal antibodies do have evidence in this setting. There are a number of drugs, including the one that I talked about, casirivimab and imdevimab. There's a compound by AstraZeneca that have been given prior to people being exposed to COVID-19 in high-risk settings like nursing homes or healthcare facilities, showing significant benefits, 80 to 90% reductions in COVID-19 over the course of months and months and months. They're not a perfect solution, but could be, administered to things like high-risk settings, chemotherapy patients, transplant patients, where the benefits of a vaccine are not going to be as profound. And certainly, again, for these oral compounds, Tamiflu, for example, which is the drug we use for influenza, we know if we give it prophylactically or even at the time of an outbreak, it can shut down outbreaks very quickly in a nursing home. And so, again, there's a lot of look at whether or not these oral compounds could be rapidly administered if there is activity in a congregate setting, and using them, again, in terms of prevention rather than necessarily in terms of early treatment. But, again, those studies are weeks and weeks and weeks away.
Okay, you ready for another odd question?
Of course.
I want to ask you about that drug that Donald Trump made so famous, hydroxychloroquine. Has anything transpired between when he took it, and a lot of people thought he was crazy for taking it because it didn't do anything, and now to make people take a second look at it because maybe it's more efficacious now?
So, there was a lot of hope in hydroxychloroquine at the beginning because it was an oral drug. It was available around the world. It was cheap and it was easy to access. And so a lot of clinical trial groups, in fact, in the first 6 months of the pandemic, it was the most studied drug for COVID-19 because everyone could access it, design their little clinical trials, and put everything together. But the unfortunate news is across all domains. So pre-exposure, post-exposure, early treatment, hospitalized treatment, there has not been seen a benefit in terms of reducing symptoms, in terms of reducing the severity of disease, or reducing death. And so, large trials, probably the best trials that were designed in the first 6 months of COVID-19, have not shown any benefit of this drug. And so, I think this is the drug that has largely been disproven through large works. It's unfortunate, but, again, nothing has transpired since then to make it come on the table, given how much study was put into it in the first place.
No benefit, but no harm either?
No, so there are some meta-analysis looking at people who have taken it. It was relatively safe. We were a part of one of those trials. But certainly in hospitalized patients, there was some concern about cardiotoxicity, patients that had more heart rhythm problems when they took the drug. And we know that's one of the characteristic side effects. There were GI symptoms for people who took the drug, and we know that's one of the characteristic side effects. So you would think, again, in a patient that's already sick and frail within the hospital or in the ICU, invoking those side effects is not going to do any good for them, and again has the potential to do harm, which is exactly obviously what we're trying to prevent with very, very medically fragile patients.
Right. Let me read a quote to you now. This is from the Medical Officer of Health for the province of Ontario, Dr. Kieran Moore, and we'll bring this graphic up if we could, Sheldon. In an answer to a question by TVO's John Michael McGrath, the Chief Medical Officer of Health, Kieran Moore, said the province is working very diligently to have a system in place across Ontario that these therapies could be available in the treatment of unvaccinated individuals. We're talking monoclonal antibodies. Here's the quote. We're looking at expanding the ability to treat individuals who are unvaccinated with monoclonal antibodies. We're also in active conversation to review with our federal counterparts the Merck oral antiviral and the Pfizer oral antiviral. These could help further protect our health system, help reduce the impact of this virus on those who remain unvaccinated, and be important options. His words, important options. Between these antiviral pills and the monoclonal antibodies, all of which we've been talking about for the last 20 minutes, do you think we now have a sort of very certain alternative to vaccines?
So I wouldn't say these are alternatives to vaccines. And the reason being is that there are a lot of steps along the way which can go wrong. Someone can minimize their symptoms, not get tested. Someone can get tested and the turnaround is too late. Someone can get tested and not able to access these compounds. And so, there's all these steps that can go along the way. Certainly, if they get scaled up, they're going to be an alternate. They're going to be a good option for patients if they're unvaccinated. It's still not as profound as getting vaccinated in terms of reducing the risk of hospitalization. We've been a part of a provincial pilot, actually, to get monoclonals into the community. And we've had good success, especially in patients who are unvaccinated. Not that we encourage that, but again, giving those people a shot to not overwhelm our healthcare system. So, yeah, absolutely. They're going to be good as a healthcare adjunct. They're going to be good to maintain ICU capacities at low levels. They're going to be good to phase up to make sure that not only unvaccinated patients, but high-risk vaccinated patients who have breakthrough infections have access to something that keeps them away from hospital. But again, I get very uncomfortable labeling this as an alternative to vaccine because again, those steps that go wrong along the way can often lead to someone being diagnosed with COVID on their way to the ICU when we had so many chances to intervene in the process to keep them out of hospital.
Gotcha. That's Dr. Zane Chagla, infectious disease physician, St. Joseph's Healthcare, Hamilton. Always good to have you on our program, Dr. Chagla. Thanks for joining us.
No problem. All the best.
There's little doubt that most of us never imagined going about our daily lives wearing a mask. But here we are. Is there an end in sight, or is the new normal now just normal? Let's ask. In the nation's capital, Rewat Deonandan. He's an epidemiologist and associate professor in the Faculty of Health Sciences at the University of Ottawa, and he makes occasional, one might even say regular, appearances on this program to explain the inexplicable to us from time to time. Dr. D, it's good to see you again. How you doing?
I'm doing great. Thanks for having me back.
Glad to see it. Is it time, in your judgment, now that 80% of us are apparently vaxxed, to get rid of wearing masks?
No, it's not time. We're still in the midst of a wave, and we still have a fair number of people who are unvaccinated. We still have case numbers climbing, and we have to use all the tools at our disposal to curtail transmission. And possibly the simplest, least expensive, best return on investment tool that we have is mask wearing. So it's not yet time to ditch that particular tool.
How often in your travels do you have people say to you, it's been about 19 or 20 months of wearing these things, and I'm sick of it, and I really don't want to do it anymore?
It used to be more common to hear that earlier in the pandemic. I think people have become a little bit accustomed to having to use it. And now you feel almost naked if you don't wear one, if you're going indoors with people that you trust, for example, or taking it off when eating at a restaurant. You might feel a little bit exposed. So we can become accustomed to the strangest things as human beings.
It's really funny how it depends on where you are. I still see considerable mask wearing outdoors. We're in Midtown Toronto right now. I see a lot of people still wearing masks outside. Do you recommend that still?
I don't recommend that. No, there's no need for that, frankly. But if it makes you feel safer and it signals to other people that you take this disease seriously, that has a social relevance and value. And also, as the winter months come, it can keep your face warmer. So there is additional benefit to wearing masks outside, but not for curtailing COVID, in my opinion.
And what do you say to people who are not yet convinced? I don't know why they wouldn't be, but there are some people who are not yet convinced that this virus is contractable through the air, and therefore you should wear a mask.
Yeah, that's a big one, right? So many of the experts were slow to come on board with this way of thinking as well. I think now we're at the point where the consensus opinion, belief, conclusion is that COVID is airborne. Not just airborne, but probably aerosol transmission is the dominant mode of transmission. And that's a big statement. The reasons we know that to be true is, in addition to the laboratory studies on things like animals being deliberately exposed to an aerosol generating ordeal and showing infection that way, we have some evidence from the real world. We have people in quarantine hotels and in cruise ships who are sequestered in their own rooms, not coming into contact with people, and yet still becoming infected because of a shared ventilation system. We have situations in hospitals, for example, where people are wearing masks regularly, a certain quality masks, which I think we could talk about later on, and yet still become infected because COVID is airborne. We have situations when people become infected by other people who have left the premises but have exhaled infectious particles and that linger in the air longer. That is the signature of aerosol airborne transmission. So that's the reality we're in right now.
You mentioned quality of masks, so let's pick up on that right now. I have seen everything from people wearing the sort of, bottom of the barrel cloth mask to N95s, to some people who just actually take their scarf, and hike it up over their face and just cover their face with their scarf. And I guess they think that does the job. Do you want to comment on the advisability of all three options?
Okay, first of all, any mask is better than no mask. That's pretty obvious. There are studies, simulation studies, that show the relative contribution value of those quality of masks that you talked about. And depending on who's wearing it, the source, the potentially infectious person, or the receiver, the potentially person who's receiving infection, and depending upon who's wearing what, the time it takes to receive an infectious dose varies. And I phrase that a certain way, right? Because we're not saying that mask wearing is going to guarantee that you won't be infected. What we're saying is mask wearing diminishes the probability substantially that you'll be infected. So the cloth masks, the scarf, that doesn't do a whole lot. If this disease were transmitted via large droplets that emerge from your respiratory system and fall to the ground within 2 meters, then those kinds of masks might trap those droplets and prevent it from going those full 2 meters. The 3-ply masks, the surgical masks, do a better job of curtailing aerosols and droplets, but they're baggy around the sides of your mouth, and so they're escaping from the sides and tops and bottoms. If you imagine an aerosolized disease like cigarette smoke, so cigarette smoke is an aerosol particle, and imagine someone smoking behind a scarf. Does the smoke get through the scarf? It does. Not all of it, but most of it does. If you're imagining someone smoking from behind a surgical mask, does the smoke get through the mask? Much of it doesn't, but a lot of it comes through the sides, tops, and bottoms. Now, if someone's wearing a fitted mask, like an N95, how much of it gets through and how much of it escapes from the sides? Not a lot. So in an aerosol milieu, in the reality of an aerosol airborne virus, the fitted mask is the best possible protection, and I think that's what everyone should strive to wear.
Okay, so that's the best option, the N95. Does that mean that you are advocating that everybody go out and start wearing N95s, budget allowing?
Yeah, I am. Now, when I say N95, I'm talking about a family of masks. The specific N95 high caliber medical grade tested mask is best for healthcare workers, and you might have a difficult time finding them. And the N95 has passed certain standards that are relevant for American and Canadian healthcare operation. But there are other things in the family, like the KN95s, for example, which pass the Chinese standard, but are just as good for you and I to wear. They're not fit tested. Healthcare workers have to have them fit tested to make sure they're sealed around your mouth. But you and I, it's okay if they're just snug against your mouth. I think everyone should wear that caliber, that quality of mask. I do. My family does.
You do under what circumstances?
All the time.
All the time?
Whenever I'm going indoor, well, not if I'm going to bed, but if I'm going indoors in places with people whose infectious status I'm not aware of, like grocery stores or stores of any kind, yeah, I wear an N95 caliber mask.
Gotcha. Okay, good to know. All right, I'm going to set up this next question by saying I refuse to confirm or deny whether or not the circumstances I'm about to describe apply to yours truly. But let's just say, for argument's sake, that in a family where everybody's negative, right? Nobody's got COVID. Maybe some mask sharing happened on occasion because somebody didn't notice that the initial that was put on the mask wasn't his initial, but maybe belonged to somebody. Anyway, you get the drift here. This is obviously not advisable, but is it harmful?
Honestly, if it's in your own family, people you live in a house with, you're already sharing each other's aerosols and germs and everything else. Sharing a mask is not going to cause a much increase in risk, to my mind. My spouse and I have shared masks inadvertently as well. Don't tell her that. She's probably hearing this for the first time. I don't think that's a big deal. Remember, the point here is to protect yourself from other people's exhalations and to protect others from your exhalations. By sharing a mask, you're not protecting each other from each other. But presumably, you're already not protecting each other from each other because you're sharing other intimate aspects of your life.
Got it. Okay, good. I think that makes me feel a little bit better. But anyway, but I'm not the only idiot out there who's done that. Sorry, I didn't mean to. No.
Oh, I'm totally on board with this.
Let me, again, this is a bit of an odd one, but, you know, we have these cloth masks as part of our lives now as never before. And eventually, you know, after a few uses, I guess they're ending up in the garbage. This may not be your area of expertise, but are we kind of setting ourselves up for an environmental problem down the road that we hadn't anticipated because, you know, we're throwing out all these cloth masks now?
Oh, it does fill me with great sadness when I'm walking the dog and I see piles of discarded masks on the floor. It reminds me of the cigarette butt era from the 70s when people just toss cigarette butts everywhere. It's not ideal. It's not great. I don't think there's any way to get around the fact that this pandemic is having a deleterious aspect on the climate, the environment in general, and mask wearing in particular, because these are high-tech materials they're made of. The N95s are made of polypropylene, for example. I don't know how well that decays. There are some studies suggesting that you can wash them to a certain number of times for reuse. Maybe heating them to a certain temperature can kill the germs sufficiently to allow you to reuse them. So there are ways to, I think, to minimize the impact, but I don't think there's a way to get around the fact that this is going to be bad for the environment in some capacity.
Do you see a lot of that happening? Because I know now, admittedly, I'm in the middle of the biggest city in the country here. I see masks discarded on the side of the streets every day. And it does kind of surprise me and borderline tick me off. What do you say what do you think when you see it?
I think I can't wait for this to be over so that we don't see this anymore. And also, I wish people just had a better respect for their environment and for the technologies that we are investing in them to protect them. So do you throw tissues away on the street after you've blown your nose? Some people do, most people don't. So this is kind of the same thing. It's not exactly biological hazard, but it shows a fundamental disrespect for the communal good.
Okay, let me come at this story now from a different angle, which is to say, I guess it was right near the beginning when we didn't know a whole lot, and when we got parcels coming to our home, and we got mail coming to our home, or if we used a door in public, we were very careful to wash the mail, wash the parcels, leave our shoes outdoors on the front stoop for a few days before bringing them inside. I mean, we did a lot of stuff. In hindsight, was all of that pointless?
Well, was it pointless? On a social level, no. It showed the extent to which we can conform to public health guidance. It probably curtailed transmission of the flu and the common cold and other respiratory viruses to a large extent. It was the right thing to do in absence of solid evidence otherwise. But yes, it may have been pointless because that's not how you curtail the spread of COVID. You curtail the spread of COVID by controlling an aerosol disease, which means high quality mask wearing, ventilation, and air filtration. Those are the best tools, in addition to testing and vaccination. Even social distancing and plexiglass barriers and stuff aren't the high impact tools that we need as much as mask wearing and ventilation.
And let me do a follow-up on mask wearing. I don't know if you notice this, but I certainly do. I notice a lot of people who still wear masks up to here, and they leave their noses exposed because, let's be honest, it's a lot easier to breathe when the mask isn't covering your nose than when it is. I don't know if they're doing that because they don't know how to wear it properly or because they've just decided, half the face is enough. Do you see this?
Oh, I see it all the time. And I think it's a function of wanting to comply with the guidance to the letter, but not to the spirit. So the letter says you must wear this thing around your face to gain entry into the store. But really, the point of it is that to prevent the spread of exhaled aerosols and hopefully to some extent prevent you from inhaling someone else's aerosols. We produce these small droplets from our respiratory system, and they are exuded from our mouth and our nose. So it's important to prevent that from happening. I don't know what to tell people other than to tell them, do you breathe solely out of your mouth? I don't think so, most people.
Right, okay. Let me ask you about schools, because of course the province of Ontario has insisted that it has flowed funds in order to make sure that our schools have better ventilation and that therefore they not become breeding grounds for COVID-19. Based on what you know, is that in fact happening?
Oh, I don't know if it's happening. I've heard stories from some schools that have taken measures. I think they're in the minority. And frankly, I know of schools with windows painted shut, for example. You can't even get a cross breeze in there. It's probably a fair investment to upgrade a filtration system to the high quality MERV 14, 16 standards, if that means anything. It's an engineering term. I'm not an engineer. There are things they can do, these things called Corsi-Rosenthal boxes that you can make in your home. You take some furnace filters of a certain quality, you slap them together and create a cube, and that is sufficient to filter out air in a room the size of a classroom. That's been shown in several simulation studies in the USA. So we're not doing everything that we can do to curtail this disease, especially now that we accept that it's airborne. And I can't say that enough. For the longest time, those are dirty words, but COVID is airborne, and we have to accept that and run with that and build our mitigation strategies around that reality.
Okay, that's schools. What other places do you think we need better solutions as it relates to ventilation, airborne, et cetera?
Believe it or not, hospitals. So hospitals have the highest quality filtration, which is the HEPA filter. But we still have people wearing those surgical masks, those blue surgical masks, the ones that are baggy tops and bottoms on the side. If you go in for any kind of medical procedure wearing an N95, they will tell you at the hospital, take that off and put on this crappy, lesser quality mask, which is infuriating. And that's just their policy. So what we need is to have N95 quality respirators worn across the board in hospitals where people are most likely to be infected and infectious. So yeah, that's a strange one, but I would count hospitals as being a place that needs to look at their infection practice and control measures a bit more closely.
While we're on that subject, can you tell me why they do that? Why you can walk in? I've done it myself. I've walked into the hospital to get a PCR test. I'm wearing a brand new N95 mask. I walk in the door, they say, take that off, and they hand me a cloth mask, and they say, put this on instead. Why do they do that?
Yeah, I've asked them, and the answer I get is twofold. One is, we can't be sure that your mask is good, just we have your word for it. And the second is, some people have an allergy, perhaps, to the mask that you're bringing in. I don't really buy either one of those arguments. I think it's more adherence to the letter of a rule that someone wrote, and someone's afraid to break the rules.
Okay, I know you're not a political scientist, but I'm going to ask you a political question anyway. Because we have seen, obviously, in the United States, the simple act of mask wearing is well beyond a public health issue. It has become a political issue in a major way. In your travels in this country, do you see that?
To a lesser extent. And there is, if you have a Venn diagram of the COVID deniers, the anti-vaxxers, and the anti-maskers, it's almost a perfect circle. There's going to be some overlap, obviously. Not all people who are vaccine hesitant share these beliefs, for example, but there is a large overlap. So I think it comes from a political viewpoint that holds independent individual freedoms as the highest possible value. And I can respect some of that to some extent, but it ignores the fact there are community responsibilities that come with our freedoms. And I think we're going to have a few years of deep introspection in this country to establish what really are the fundamental Canadian values. Do we value community well-being above the sacrosanct nature of individual rights? I think we do.
That's Dr. Rewat Deonandan, epidemiologist and global health researcher at the University of Ottawa, whose visits to our program we really do appreciate. Thanks so much, and take good care.
Thank you so much.
And that is the agenda for this Thursday, December 2nd, 2021. Tomorrow, Nam Kiwanuka finds out why Giller Prize-winning novelist Ian Williams' latest book is nonfiction and, reluctantly, political. I'm Steve Paikin. Thanks for watching TVO, for joining us online at tvo.org. And Nam, we'll see you here tomorrow.
The Agenda with Steve Paikin is made possible through generous philanthropic contributions from viewers like you. Thank you for supporting TVO's journalism.